Hi, I'm Dennis Nash, and this lecture is on the dynamics of infections in populations. We'll cover key concepts in the dynamics of transmission of infections, including the reproductive rate and herd immunity. We'll introduce you to mathematical models in infectious disease epidemiology, and then we'll cover an example of disease eradication. We'll cover the concept of disease eradication, and we'll use an example from Nigeria. And finally, this is just a reminder for next Sunday, your first homework will be due, and you'll be submitting it via Blackboard. Please be sure not to include your name on the document because we grade them in a blinded fashion. Blackboard will keep track of whose homework is whose. Okay, so this slide shows a schematic of the spread of an infection in a population. The dark circles represent cases of the infection, and the dark arrows represent the spread of the infection from one case to another. The light circles represent people who are not infected but could be susceptible to infection. They may or may not be exposed to a case. A primary case, shown on the left of the schematic, is the person who first introduces the disease into a population, such as the first case to occur in a household or at a school or a town. And secondary cases are those individuals that are infected by a primary case. So there can be tertiary cases also that arise from the secondary cases and so on, representing subsequent generations or waves of transmission from the primary case. In contrast to these terms, an index case shown here is defined as the first case of an infection that comes to the attention of public health authorities or epidemiologists who may be investigating an outbreak, for example. The index case may or may not be the primary case or even a secondary case. Indeed, most outbreaks are not discovered until transmission has been underway for some time, sometimes a few waves into transmission. And the first case associated with an outbreak may be identified weeks or even months after the primary case as a result. So going back to the epidemiological investigation of Ebola from last week's reading, the primary case associated with the emergence of Zaire Ebola virus in this outbreak in Guinea is believed to have been a 2-year-old child who became ill and died in early December 2013. However, it was the subsequent cases of an unusual cluster of illness and hospitalizations that alerted public health officials to the outbreak. And so the index case would be among this subsequent cluster of patients because it was the first case in the outbreak to come to the attention of the epidemiologists and health authorities. So if you remember that the incubation period of Ebola is about 4 to 10 days on average, in this example, the index case occurred several waves of transmission after the primary case. An important concept and indicator of epidemic potential is the basic reproductive rate, or R0. R0 is defined as the average number of individuals directly infected by an infectious case during their entire infectious period. Importantly, when they enter a totally susceptible population. And by totally susceptible, we mean that no one else in that population has any immunity to the infection, either by virtue of having had the infection in the past or by having been vaccinated. As you might imagine, the basic reproductive rate, also called the basic reproductive number, is something that varies from one agent to the next. And this slide shows the basic reproductive number for selected vaccine preventable diseases that are spread from person to person, and you can see that they really vary a lot, with some agents having much more potential for epidemic spread than others. So for example, you can see diphtheria has an R0 of 6 to 7, meaning that each new case introduced to an entirely susceptible population will result in another 6 to 7 cases on average. And compare that to an infection like measles or pertussis, which is much more epidemic potential, where each new case results in maybe 12 to 18 new cases on average. And we'll get to the concept of herd immunity later, but the proportion of people that need to be immune in the population in order to protect against outbreaks of these infections is obviously related to the R naught parameter, and so the higher the R naught, the higher levels of immunity you need to achieve to have herd immunity. And as a result, you can see, the vaccine immunization levels that are needed in order to maintain herd immunity in the population. They're very, very high for many of these vaccine preventable diseases. And there have been many other published estimates for other infectious diseases that are spread from person to person. You can see some of them here. And lastly, there have been a lot of published estimates of R naught for the SARS-CoV-2 virus from outbreak investigations, and most of them range between 2 and 3. So each new infection of SARS-CoV-2 results in an additional 2 to 3 individuals infected. And finally, just remember that the R naught applies only to a totally susceptible population. When people are immune by virtue of having been infected and then recovering, or through vaccination, or if they change their behaviors to avoid spreading or acquiring the infection, the potential for epidemic spread is less, and we'll talk about that shortly. But I just want to point out here that you can really only estimate R naught when an infection is spreading in a totally susceptible population. So the estimates for R naught tend to come from outbreak investigations soon after the emergence of an infection, like the investigations of the first 400 cases of SARS-CoV-2 in Wuhan, China, that we covered last week. And you may remember they found an R naught of 2.2. But back to our schematic of spread of an infection in a population, let's further assume that this is a totally susceptible population and that our outbreak investigation has found all cases and has determined from whom and to whom all cases were transmitted. How can we estimate R naught? Well, returning to the definition of R naught, which is the average number of people infected by each case in a totally susceptible population, which we're assuming here, we can operationalize the definition of R naught using the information shown here. And basically, you need to count the number of people that each individual case goes on to infect, and then take the average, right? So if we start here with the what we were calling the primary case earlier, this case infected 1 person, and then this case went on to infect 2 people. This one went on to infect 1. This one went on to infect 3. This case went on to infect 2 more. This one went on to infect 1, and so on. So you can count, based on what we can see here, you can count the number of new cases that resulted from each individual case, because this information would be gathered by a very detailed outbreak investigation. And you can take the average. And if you do that for this particular infection, you would add up all of the infections resulting from each case and take the average by dividing by the number of cases. And in this case, you get an R naught of 1.5. So each of these, whatever agent this is, each of these cases result in an additional 1.5 new cases on average. And this gives you a sense of how the transmission, how epidemic spread can be faster from one R naught to the next. So here we're showing on the top the primary case of Ebola, say, or patient 0, and with an R naught of 2, Ebola, this person would go on to infect on average 2 people, and they in turn would go on to infect 2 more people. So by wave 2 of transmission, there are 7 cases that have amassed in total. But if you look at SARS-CoV-1 with an R naught of 4, you can see that the numbers of cases with each wave rise much more rapidly, so that by the end of wave 2, there are now 21 people. So R naught refers to the potential for epidemic spread and how quickly they may increase from one wave to the next. There's something very intuitive about the basic reproductive rate, which is that by definition, if R naught is less than 1 for an infectious agent, it will eventually disappear when introduced to a totally susceptible population where no one's immune. If R naught is exactly equal to 1, then that means each case essentially replaces itself on average. And so in that situation, transmission will be stable and the infection or disease will become endemic. If, however, R naught is greater than 1, then each case replaces itself and then some. And in these situations, the infection or disease will grow and cause an epidemic. The size of the epidemic and how fast it will spread depends on a variety of factors, but R0 is a key factor in determining that. And once an agent begins to spread in a population, things begin to change and people become immune in the case of infections that are immunogenic. But in a situation where an immunogenic or an immunogenic infectious agent or a vaccine-preventable disease is spreading in a population that is not totally susceptible, where some proportion of the population is immune, we can estimate a parameter called the net reproductive rate, or also the effective reproductive rate. And this parameter depends on R naught as well as the average proportion of people who are immune in the population. Of course, other things can change the basic reproductive rate, such as the behaviors in the population, and we'll come back to that shortly. But again, intuitively, when people in the population are immune, then the net reproductive rate will be lower than the basic reproductive rate. And when a large proportion of the population is immune, the net reproductive rate will be proportionally lower, thereby effectively reducing the potential for epidemic spread. And you can calculate the net reproductive rate using this formula, which essentially reduces R naught in proportion to the proportion of people who are immune in the population. So here's a visual of how immunity can impact the reproductive rate for an agent with a basic reproductive rate of 4. So each new case is giving rise to 4 new cases, creating the potential for epidemic spread, because R naught is greater than 1, in this case quite a bit greater than 1. On the top panel here, in this slide, we have the situation where a single case of infection is introduced to a totally susceptible population at time t, and this single case gives rise to 4 new cases at time t plus 1, who in turn each give rise to 4 new cases for 16 new cases, or a total of 21 cases by time t plus 2. But here on the bottom panel, we have the situation where 3/4 of the population is already immune at the time the case occurs. And those immune individuals are indicated by the dark shading. And in this situation, the net reproductive rate is 1. And each case really only gives rise to only 1 new case, greatly limiting the spread to only 6 cases by time t plus 2. So you can get a sense of how immunity can slow the spread for an effective reproductive rate that is lower. Intuitively, from prior slides, it would follow that the more people who are immune in the population, the more the population would be protected against epidemic spread. This is the concept of herd immunity, which comes from veterinary epidemiology, where immunization was critical to protect herds of cattle. So herd immunity is defined as the immunity of a group or community. It's the resistance of a group to invasion and spread of an infectious agent based on the resistance to infection of a high proportion of the individual members of the group. So as the proportion immune increases, the potential for spread decreases. But at what level of immunity in the population is the herd protected against outbreaks and epidemic spread? Well, it turns out that you can estimate it by rearranging the formula for the net reproductive rate. Basically, you achieve herd immunity when the net reproductive rate is less than 1. So in the equation for the net reproductive rate R, you set R to be less than 1 and solve for P, the proportion immune. So in the example of measles with an R naught of 15, what proportion of the population needs to be immune to prevent measles outbreaks? If you set R to be less than 1 and use an R naught of 15, we can solve for P and get 93.3%. So to prevent measles outbreaks, a very high proportion of the population needs to be immune. And this is why there's so much effort put into ensuring that all or nearly all children are immunized against measles. And this level of vaccine coverage is very challenging to maintain, which is why we're also seeing increasingly measles outbreaks around the US, including in New York City. One other point here is the P refers to the proportion that is immune, not the proportion that are vaccinated. So since not all vaccines are 100%, in order to achieve a proportion immune in the population of, say, 93.3%, you might need to vaccinate, 97% to account for the fact that the vaccine is not 100% effective. So you always need to take into account vaccine effectiveness when trying to target the levels of coverage you need in order to get to the goal of herd immunity. And so if you were to plot P as a function of the basic reproductive rate in this equation, you can see how once you get beyond a basic reproductive rate of, say, 2, more than 50% of the population needs to have immunity in order to prevent spread, and it's greater than 90% once you get above 10, basic reproductive rates above 10. So you may be wondering what determines R naught. This is also sort of intuitive. To understand this, though, we need to go back to some of the concepts we covered last week, like infectivity and duration of infection, but also to look to human and societal behaviors that determine the frequency of exposures that can result in transmission. In fact, R naught is dependent on the proportion and proportional to all three of these things. So we define R naught as the product of beta, kappa, and D, where beta is the risk of transmission per contact or exposure with an infectious person, and this is related to infectivity, right? The risk of infection will depend on the how infectious the agent is each time you come in contact. If it's very infectious, the likelihood of becoming infected could be higher. Kappa refers to the number of potentially infectious contacts or exposures per unit time. So if the exposure is something that frequently puts you in contact with a potentially infectious or an infectious person, then that can also increase the risk. So it's not just the risk of infection given an exposure, it's how frequently the exposures are occurring. And also, D is the duration of infectivity of an infectious person. So that relates to the infectious period. So you can imagine that the number of cases that each person could give rise to on average will be related to how long they're infectious. So if they're infectious for a long period of time on average, then there's more opportunity to continue to spread the infection. And all three of these things can really vary by contact and exposure, whatever the type of exposure is that we're talking about. So here are some examples. Public health interventions for epidemic diseases can be thought of as strategies to lower R naught, essentially. Depending on the agent, it may not be possible to get R naught to be 1 or less than 1, but the impact can still be reduced by lowering it, say, from 3 to 2. So let's look at a few public health strategies to control infectious disease spread and how they relate to the three components of R naught. So, for example, condom use to prevent spread of sexually transmitted infections effectively reduces the risk of transmission per contact, or beta. Another strategy to prevent the spread of sexually transmitted infections is encouraging fewer sex partners, and so this effectively lowers the number of infections per the number of infectious contacts per unit time, or kappa. And there are also interventions that reduce the duration of infections, such as earlier diagnosis and treatment of TB or HIV. For these conditions, treating them also ensures that the person who's infected is no longer infectious, resulting in both a clinical and public health impact. In the field of HIV, we call this treatment as prevention. And what about some of the non-pharmaceutical interventions for SARS-CoV-2 listed here? Can you identify which component of R naught they're talking about, or which component of R naught they're targeting here? So hand washing, cloth masks. What component are of the basic reproductive rate might be represented by these non-pharmaceutical interventions? And lastly, I want to bring up an important point, is that when you have a strategy to prevent or control or eliminate an infectious disease, you can have a bigger impact if you can focus on more than one component of R naught. And why? Because the effect of on the net reproductive rate in that situation is really multiplicative or synergistic. So a public health strategy for SARS-CoV-2 that reduces beta by 30%, say through increased hand washing, and reduces kappa by 30% through a universal mask policy, actually reduces R naught, or gets to a net reproductive rate that's 50% lower than R naught. And in the case of SARS-CoV-2 with a basic reproductive rate of 2.5, the net reproductive rate would be 1.25. So still not enough to eliminate the infection as a cause of disease in the population, but enough to begin, flattening the so-called curve. And add that to another strategy to reduce kappa, like test and trace, and you could potentially get the epidemic fully under control. Indeed, New York City achieved a net reproductive rate of less than 1 for SARS-CoV-2 in the spring, as have many other cities and countries around the world. And if you look at the trajectory of the SARS-CoV-2 epidemic in New York City, you can see that all of the measures that were put in place, starting with lockdown, were successful at reducing the number of cases and also the number of hospitalizations and the number of deaths. And there are about 2,000 people diagnosed with SARS-CoV-2 every week in New York City today, and about 20 to 30 deaths per week. Deaths are decreasing with time. So the net reproductive rate was reduced substantially in New York City, and right now it's kind of behaving like an endemic infection, with cases neither increasing nor decreasing, but remaining constant. So citywide, that the net or effective reproductive rate is probably about 1. However, it's important to remember also that the reproductive rate is an average, and we're looking at this trend data and making inferences about the whole city, but the citywide trend could really mask microepidemics in smaller geographic areas or populations where transmission is increasing. And this is why it's really important to monitor these trends, not just citywide, but by neighborhood and by socio-demographic factors. And just showing a map here that shows the more recent data on the number of deaths that are occurring in different neighborhoods. And there are 0 deaths in some places, and upwards of 10 and 20 deaths in other neighborhoods. So while the effective reproductive rate might be about 1 or even less than 1 in some neighborhoods, it may be greater than 1 in others. So mathematical modeling is an important tool for infectious disease epidemiologists. And in fact, an entire course is really needed to do the topic justice, but at least for the purposes of this course, we'll have a lecture here, part of the lecture here, to introduce you to some of the fundamentals of the simpler mathematical models used in infectious disease epidemiology. So what are they used for in epidemiology? How are they useful? Mathematical models really are basically taking these complex systems and reducing them to mathematical descriptions. And they rely on explicit inputs and assumptions that rely on what we know about the infectious diseases, and try to model them mathematically. So they take these very complex systems and simplify them in ways that try to use mathematics and statistics to make predictions about how the infectious diseases will behave in populations in the future, going forward, or under different circumstances. Why are they useful? Well, since transmission of infectious diseases can be such a complex phenomenon, the the models can be one of what are many tools that are needed to help predict what might happen in the future. But since it's impossible to predict the future, mathematical models themselves are always wrong to some extent. They can provide some useful approximations, though. The models can help assess what infectious diseases might do under different epidemic scenarios, such as comparing what might happen if schools were closed versus if they remained open in the context of, say, a flu outbreak, or implementing versus not implementing a robust contact tracing and testing and contact tracing program in the middle of a coronavirus outbreak. They can help give insights also into what factors are the most important drivers of incidence and prevalence among the many factors that could be important. And at the end of the day, if we don't have mathematical models that are well developed, we're left to our own intuition to try and guess what infectious diseases might do going forward, or how we might best control them. And Nelson and Williams refer to these this kind of intuition as mental models, the kind of models you make in your head about how you think based on what you know, how the infectious disease might behave. But this can be a very subjective exercise and might not fully account for the complex interrelationships that might exist between the infection and all the spread that can happen in human populations. So mathematical models can help improve, or at least inform, the mental models that we use to make actual decisions about what to do in the real world. As you might expect, mathematical models work by using what we know about the biologic or immunological and epidemiological properties of infectious agents that we've covered so far in the course. So the models require input parameters and assumptions regarding things like the incubation period, or the infectious period, or the duration of infection. And if some of these properties aren't yet known, for example, if it's a new agent and we're still learning about it, then the models need to make assumptions about the plausible values for these things, or what the range of values might be. So, for example, if we don't have good estimates of the infectious period for an agent, but we know a likely range of possible values, then mathematical models can take the range of values and make predictions across the range of possible values. So it can incorporate some of the uncertainty that we have about the infectious agent into the way the model works. The most basic mathematical model for infectious diseases is the SIR model. And this model is intended to reflect a hypothetical scenario for an infection that confers immunity after someone recovers, so they're immune, and that also the entire population is susceptible at the start of the modeling process. So those are two very important aspects of the hypothetical scenario for these models. Other important assumptions of the SIR model include that the population is fixed, so there aren't people coming in or out of the population, and that there's no latent period between becoming infected and being infectious. In the SIR model, all infected persons are infectious from the time they're infected to the time that they're recovered or removed from the population. So for the SIR model, then, we let the population be divided into three mutually exclusive classes, or states, or sometimes we'll call them compartments. And these are the S, I, and R states. S stands for the susceptible state, and it is the proportion of the population susceptible to the infection. I stands for the infected population, and that they're also by definition infectious in this scenario. And R stands for the recovered population, which is the proportion of the population that is recovered or immune to the infection. So starting at time 0, then, in the SIR model, before the model begins to predict what will happen in a hypothetical population, at time 0, everyone is in the susceptible group. So S equals 1 at that time, and the number infected equals 0, and the number resistant equals 0. And then you go through the exercise of introducing one infected person into the hypothetical population. And the model will then will then calculate how S, I, and R will change over time given what it knows about the infection. So what it will tell you depends on the properties of the agent that you as the modeler provided. Like, what is the infectivity? What's the incubation period? What's the basic reproductive rate? Or if you don't know it, what about beta, kappa, and the duration of infection? And with these factors as inputs, the dynamics of transmission in the population, or the rate at which people move from the susceptible to the infectious to the recovered compartments, can be modeled using equations. And so there's also a slightly more complicated model, which is the SEIR model, and that includes a compartment for those who are exposed but not yet infected or infectious. This is another one you might see in literature in some of the papers that you're reading. So how can these infectious disease dynamics be modeled using equations? Well, here's some of the details shown with some basic calculus, which you don't need to know if you haven't had calculus. Don't worry. Just conceptually here, these equations model change over time in the S, I, and R states in the model. So how does the proportion of people who are susceptible change over time? ds dt is the negative beta times kappa times the proportion susceptible times the proportion that are infectious, right? So this is the number of susceptible is something that is going to decrease over time. The change in the proportion infectious over time, or di dt, is beta kappa times the susceptible proportion and the infected proportion minus 1 over the duration of the infection. And the change in the proportion resistant over time is dr dt, which is equal to 1 over the duration. Conceptually, you can think of all the kinds of interactions that would occur in a randomly mixing population. The one interaction that the model is most concerned with is the interaction that happens when a susceptible meets an infectious person. This is the situation where transmission can occur. Transmission cannot occur in situations where one susceptible person meets another susceptible person, and all these other permutations. Susceptible meets recovered, infected meets infected. These occur with some probability, but the transmission occurs only in these scenarios. And you can solve these equations on the prior slides to come up with a formula that you can actually use in a spreadsheet to predict how an infectious disease might behave over time in a population. And so you can predict what happens at time, or calculate what would happen at time t+1, given where things were at the prior time point for each of the parameters in the model. But you start at t equals 0, with 100% of the population being infected. So in an example here, which I plugged into a spreadsheet with a population of about 1,000 people, here I'm showing the proportions in each of these compartments on the left over time, and here I'm showing what it would look like if you used a hypothetical population of 1,000 people, so you can see how many actual people would be in each category over time. But we make some assumptions about the agent. Let's say it's an agent for which the number of potentially infectious contacts between a person who's infectious and a person who's susceptible, that's beta, is about 0.15. And let's say that there are 12 such contacts on average per week. Maybe the type of contact is, like, say, riding the subway, and that's kappa. And then the duration of the infection in this case is 1 week, d. So using the formula, and beta kappa d, we can calculate the basic reproductive rate to be 1.8. So each new case of the infection, in this case, infects 1.8 other people in the population on average. And so if you put this information into the spreadsheet, with the formulas on the prior slide, we can estimate the number and proportion of people in each category, S, I, or R, after an infectious person is introduced. A single infectious person is introduced at time 0 when the entire population is susceptible, and we can apply those proportions to the hypothetical population to see the numbers and how they change over time. So I did this for all the way out in time until things became a steady state, and this is just sort of showing the plot of those numbers. So we start here at time 0 with 1,000 people who are susceptible for this hypothetical agent with an R0 of 1.8, and we also are starting at time 0 with no one who is infected and no one who has recovered. And then as time moves forward, you can see the number of infectious people increase, as shown here in the green. This is essentially the epidemic curve. It peaks about week 10 and then begins to decline over time. And that's when at that point the net reproductive rate is clearly decreased and the infection ultimately goes away. The purple line shows the number of people in the population that are recovered and immune. And for an R0 of 1.8, we can estimate the proportion that needs to be immune in order to prevent outbreaks going forward, the herd immunity proportion. And for an R0 of 1.8, it's about 44%. So there remain also susceptibles in the hypothetical population at the end of this outbreak, but because of herd immunity, they are protected. So some strengths of the SIR model include that it is a model that corresponds well to a lot of infections of public health importance, pretty much the childhood infections, vaccine preventable infections. And it's also useful to begin to understand how infectious disease dynamics, it's instructive for understanding infectious disease dynamics and how they evolve over time. But there are some limitations, of course, of many models, or that they're simplifications of reality. So this is a simplified model. It does require many assumptions, and which often are not met in the real world. And it doesn't account for a lot of variable real-world situations, such as variable ages and urban and rural contexts, where things may be different, urban and rural contexts. So the kappa could be different from one setting to the next. People can change their behavior, those who are ill and also those who are worried about becoming ill, and that could affect how kappa and beta, it could affect the values of kappa and beta over time. So, but the model, as we have shown here, does not allow for changing kappa and beta or anything like that over time. And there can also be multiple modes of transmission that with variable risk. So we might want to account for the fact that there are different kinds of exposures that could occur in the population over time. It's also a model that's not applicable to other types of infections, such as those that aren't directly transmitted, those that don't confer lifelong immunity, and where persons don't necessarily recover or clear the infection. So chronic infections it's not necessarily applicable to, such as HIV. And so that's a limitation as well. And finally, it's deterministic. It's purely mathematical. The equations determine what will happen over time. And as we know, there's a role of chance in a lot of the interactions that occur in the world, and that there's a probability that's associated with transmission of infectious diseases in the real world. So mathematical models that are purely mathematical and don't take into account any role of chance are called deterministic models, but there are stochastic models that we're not covering in this course that can bring in this component into the modeling process. So I was showing you a model used in Excel, but there are also a lot of modeling software tools out there that are useful for mathematical models. I'll just show you, give you an example of one here from called Stella. They did a nice, they developed a nice model during the H1N1 outbreak to model and try to get at what was an important question at the time, which is, how long students should stay out of school in the midst of an H1N1 outbreak if they have symptoms. So imagine a high school with a population of 1,000 students. A single student has been exposed to the H1N1 flu but is not yet showing symptoms, and the model was set up to do a few things, like to estimate how many students might get sick, but you can also explore how much vaccination of students could have on the trajectory of an outbreak in that situation. And you can also explore the question of whether or not the number of days that an infected person stays home matters in terms of limiting the spread in the school population. So the investigators developed an SEIR model here, and you can see the schematic. The model has a few more compartments than the simple SIR model, including a compartment for being immune right here prior to the start of the outbreak through vaccination. And the compartment on the bottom right here represents time spent at the home versus school. So it's kind of like an isolation compartment. And each one of the circles represents a parameter that the model uses for an input. So what's the percent vaccinated at the time of the start of the model? What's the effectiveness of the vaccine? And information about the number of infected contacts per day, the total number of contacts per day, the risk of exposures. All of these things are explicitly described in the model here. And these valves here, these little valves, represent parameters that the user can vary to see how changing these values impacts the behavior, the predicted behavior of the infection in the population. So, for example, tweaking the valve for the percent vaccinated will allow you to see the effect of vaccination on the total number of sick students, and tweaking the valve on the average number of days spent at home will allow you to assess the impact of longer versus shorter home isolation periods. And so this is the model output here, and you can see it's nice. It allows you to really sort of tweak little dials to see how it changes in an interactive way. But in this population of 1,000 students, it predicts that without any vaccination, and if students aren't staying home any days when they're sick, pretty much the entire school population is going to become infected with H1N1 within about 40 days. But if you tweak the valves in that scenario, you can explore the effect of different scenarios, such as requiring that sick students stay home for longer periods of time, or by increasing the vaccination rates. And you can see with progressively more intense control measures, the number of sick students over time becomes much less. And you can also look even at so you can assess the relative importance of vaccination versus staying at home, or you can look at their combined effect when you implement both at the same time. During the West African Ebola outbreak in 2014, there were several models that were developed to try to predict outcomes under different scenarios. And there was one, the New York Times presents here on the left some results from Columbia University's Earth Institute's model, and it shows the actual number of cases leading up to August 31st, I believe it was, and then predictions about cases and deaths under different scenarios on the right here. One where conditions deteriorate and the infection rates become worse than they had been to date. One where the infection rate stays about the same as it was on August 31st, and one where the conditions improve, for example, through more effective outbreak control measures. And you can see the predicted outcomes from this model. And you'll remember from our last lecture that by the end of the West African Ebola outbreak in 2014, there were about 15,000 cases and 11,000 deaths. So just to put these numbers in context, by the end of the outbreak, there were about 15,000 cases and 11,000 deaths. And on the right here, we see another model that the CDC released, and they predicted, in a worst case scenario, between 500,000 and almost 1.4 million cases if there were no effective interventions to be implemented. But under their best case scenario, which included about 70% of Ebola patients being isolated and treated, it predicted between 11,000 and 27,000 deaths. So it seems like there are worse scenarios modeled by each of these different models that got into the ballpark of what actually ended up happening with the Ebola outbreak in the subsequent months after August 31st. Now, those were models that tried to predict the spread of Ebola within West Africa where the outbreak was occurring, but there were also some models that attempted to predict whether and where there might be spread outside of West Africa. And this model used data on air traffic connections from West Africa to the rest of the world to try to predict where cases outside of West Africa might be more likely to appear or to be imported to. Importantly, they developed a model that needed to be calibrated. It needs to be able to show that it can predict what happened in the outbreak leading up to the time that they're going to move into a projection region. So your model should be good at predicting the past, and that's called a calibration. You calibrate your model to make sure that it is consistent with everything that has happened to date. And then you can feel a little bit better about how it might perform predicting the outbreak trajectory in the future, or where the outbreak might be headed. So this relates to the, of course, knowing just the general outbreak trajectory and having a model that predicts what's going on in West Africa is important to this question, because it relates to the probability that someone with Ebola would board an outbound plane during their incubation period, or in other words, prior to showing any signs and symptoms, because there were methods to screen for people with symptoms at airports so that they didn't travel. So they combine this information, their model on the actual outbreak, and the numbers of information on the typical number of flight passengers from the region to other parts of the world, and simulated which countries might have the highest likelihood of importing a case of Ebola over time. And the time of this work, Nigeria had already experienced its first case importation, which, as we discussed last week, was successfully identified and contact traced, and the spread was limited to only about 20 cases there. But the graph here shows the top 16 countries and their predicted probabilities of importing a case during the early September 2014 on the top, and late September on the bottom as the outbreak was progressing. And within these weeks, they also modeled different approaches to case detection during travel, such as temperature checks at the airport prior to boarding flights or prior to entering countries. In both time periods, Ghana and the Gambia had the highest probability of an imported case, but countries outside the region also had high probabilities, such as the UK and the US. And here what we're showing is the predicted size of the outbreaks that would occur if an exported case, if a case was imported. And you can see that for each, the early September projection period and the late September period. And how well did the model do? Well, we can look back now and we can see again from last week, showing the distribution of actual Ebola cases outside of West Africa, and the model did pretty well. There were some countries with imported cases that weren't on the list, such as Spain and Italy. And the initial case in Spain actually was not someone on a commercial flight. They were working in West Africa and medevac there, so that wouldn't have been predicted in the model. And many of the imported cases were, in fact, healthcare workers who had been treating Ebola patients in the region. And this is a paper from your readings this week. It's a modeling paper that looked at the feasibility of controlling COVID-19 outbreaks by isolation of contacts, of cases and contacts. So, they basically start out with the notion that case isolation and contact tracing is an important method to control outbreaks, and it's also one that we're using for coronavirus disease in the pandemic. And so they wanted to use a mathematical model to assess the extent to which isolation and contact tracing could actually get an epidemic under control when cases are imported and discovered in a place where they haven't been occurring before. And so they developed a stochastic transmission model, which is one that does include, take into account the role of chance in disease transmission and other outcomes. And they wanted to look at the effectiveness of contact tracing and case isolations at controlling this particular outbreaks as a result of this pathogen. So they were looking to see how the likelihood of controlling outbreaks varied based on the number of initial cases that were introduced into the population, based on low, medium, and high estimates of what the basic reproductive number is for SARS-CoV-2, based on how long it takes between symptom onset and isolation, the probability that contacts were traced. So did they trace 50% of the contacts? Did they trace 80% of them? And the proportion of transmission that occurs prior to symptom onset, and also importantly, what the proportion of transmission that is resulting from subclinical infections or asymptomatic transmission. This is really hard to control through testing and contact tracing. So they modeled scenarios that looked at the extent to which asymptomatic transmission was going on and how that affected their results. So they were simulating outbreaks and whether or not the outbreaks whether or not the outbreaks were controlled under different scenarios. And they defined outbreaks as being controlled as if when transmission stopped within 12 weeks of the initial cases, or before 5,000 cases were reached in the outbreak. So they say here they measured the success of controlling outbreaks using isolation and contact tracing and quantified the weekly maximum number of cases traced to measure the feasibility from a public health standpoint. There's a table in the article that shows the input parameters and some of the assumptions that they used in their model. So here they looked at a short and long onset to isolation period, one that was about 3.4 days and one that was about 8 days. And these many of these parameters came from literature. These are what people were reporting about how long it was taking to get people into isolation, and so they modeled them. They brought in information on the incubation period. They used 5.8 days. We've seen estimates of 5.4, and they looked at ranges, importantly, for all of these. And then the serial interval, which they didn't get from the literature. They made some assumptions about what it might be. They looked at different scenarios of initial cases. So if you have an outbreak that starts with 5 cases versus 20 versus 40. And then they also looked at the extent they also looked at how effective the tracing program was depending on what proportion of contacts could actually be traced. And so these are some of the inputs and assumptions that went into their model. And these are some of their results here. And so just to try and orient you here, this graph shows how things vary depending on the number of initial cases. This graph shows the short versus long interval between onset of symptoms and isolation. So, how long it took to get people isolated. This slide shows the proportion of transmission that would be happening before the onset of symptoms. So 30% would be a high level of transmission prior to symptom development. And then this is looking at the proportion of infections that are completely subclinical, completely asymptomatic. And so what you can see here on the y-axis, it's the proportion of simulated outbreaks that were controlled. And on the x-axis, it's the proportion of contacts that were successfully traced by the program. So in this situation, where there were 5 initial cases with no contacts traced, 40% of the outbreaks would result in being controlled. Whereas if you move all the way out to 100% of the contacts being traced, nearly all of the outbreaks would be controlled in that situation. And as you increase the number of initial cases, it takes longer, you have to trace a higher proportion of contacts in order to successfully control the outbreaks. Ultimately, if you can get 100% or near 100%, you'll be able to control most of the outbreaks, regardless of how many initial cases are there. So similar scenarios, you can see the impact of long versus short delays between onset and isolation. And when the delay is long, you need to trace a much higher proportion of contacts in order to get outbreaks under control. And similarly, when you have a lot of transmission going on before the development of symptoms, it's very hard to control. It's very hard to control the outbreaks until you can get out to a very high proportion of tracing all of the contacts. 100% here will get you controlling most of the outbreaks. And lastly, you can see subclinical infections. So the authors concluded in most scenarios, highly effective contact tracing and case isolation, meaning they're doing it quickly and they're tracing all the contacts, is enough to control a new outbreak of COVID-19 within 3 months. And the probability of control decreases with long delays from symptom onset to isolation, with fewer cases ascertained by contact tracing, and with increasing transmission, proportion of transmission before symptoms. So this is a very useful mathematical model to give you a sense of how much tracing of contacts needs to actually happen, and how quickly they need to be traced after they have disease onset, before you can expect your contact tracing program to begin to be able to control your local outbreaks. So lastly, we'll cover the concept of infectious disease eradication. And eradication situates itself in across sort of a continuum of efforts to manage the burden of infectious diseases in populations. And we'll just start at the top here. The first level is sort of control, which is about managing or reducing the incidence and prevalence and morbidity to some locally acceptable level. So it doesn't go away, but you're doing something deliberate to manage the disease burden, including interventions to keep the burden low. The next sort of level is focus on eliminating not necessarily the infection, but the disease that the infection causes. So trying to really focus on reducing the incidence of disease, the morbidity associated with an infection. Next is actually trying to eliminate the infection altogether, and that is about reducing the incidence to 0 of the infection in defined geographic areas as a result of deliberate efforts and interventions and strategies. And right now we're going to focus on this notion of eradication, which is the permanent reduction to 0 of cases all over the world. So there would be no incidence of infection caused by a specific agent. And that would happen as a result of deliberate efforts. And after you eradicate the infection, there is no longer any intervention measures needed to manage the burden. There's only been one example of a disease that's been eradicated, and that's smallpox. Lastly, there is this notion also of extinction, which is not only have you eliminated or eradicated the infection from spreading around the world, but the agent no longer exists in nature or in the laboratory. And there are no examples of this, and that's because even though smallpox was eradicated, it is maintained in laboratories in the United States and in Russia. So there are some key criteria in considering, when a disease could be eradicated. And the first is that there has to be biological and technical feasibility. So you need it has to be technically possible and feasible. So a highly effective intervention needs to exist, such as an efficacious vaccine, and also because it's incredibly hard to control what's going on in the animal kingdom. The life cycle of the pathogen should completely depend on humans, because that's really the group that we can focus our interventions on the most. But in addition to the feasibility, there needs to be consensus on the costs and the benefits of doing the disease of aiming to eradicate the infection from the face of the earth. And also, you need to have societal and political support to do it. This is something that requires cooperation across governments and countries. And it's something that competes for resources to do other things. So here's a list of past eradication efforts. Smallpox was not the first disease that was attempted to be eradicated. There were others before it that were all unsuccessful. Yellow fever, yaws, and malaria were all attempted prior to smallpox, and none of them were successful. And if you look at some of the criteria that I mentioned, at the end of the day, there were not the biological and technical feasibility criteria were not met. In the case of malaria, there was consensus on costs and benefits of achieving eradication, but not so much for yellow fever and yaws. And same for broad societal and political support. It was there for malaria, but not for yellow fever and yaws. But if you look at smallpox, all of these four criteria were met across the board. And here, so smallpox, as I mentioned, was the only example of a successful disease eradication program to date. And here on this slide shows a picture of the last case of smallpox, which occurred in Somalia in 1980. So this slide shows from your reading the two active eradication programs that are happening right now. So those are polio and dracunculiasis, which is also known as Guinea worm. Polio is a virus, dracunculiasis is a parasite, but you can get a sense of the different aspects related to the different criteria here for each of these active eradication programs. A word about surveillance in the context of disease eradication. In surveillance is that process by which health authorities are looking for and monitoring cases of an infection in the population, and so to track it for disease prevention and control. And in the case of disease eradication, it's a process where the surveillance activities and the disease control activities really need to be closely linked or even integrated. So the people doing the surveillance might also be doing the disease control response or eradication response activities, so maybe vaccination. It's also more focused on finding cases in a very timely fashion and finding every single case, as opposed to not complete enumeration of all of the cases, which often happens in disease surveillance. In the context of disease eradication, it's really important that surveillance enumerate every single case in the process. And lastly, it gathers critical information for monitoring and evaluating the efforts of the disease eradication program. So we're going to delve in a little bit to an example of an active eradication program for Guinea worm or dracunculiasis. I mentioned there was one of the 2 active eradication programs going on globally right now, and I'll draw on an example from Nigeria, which I had the opportunity to work on Guinea worm eradication in Nigeria several years ago, and I'll draw on that experience to give you a sense of how that eradication program was working there. So just to set the stage a little bit, Nigeria is a very large country in West Africa, the 10th largest country in the world with a population of more than 137 million. This slide is a little bit out of date. It's actually much more than that. It ranks among the poorest countries in the world, but it's also very diverse in terms of ethnic and linguistic groups. And it's said that 1 out of every 5 Africans is a Nigerian. In Nigeria, the life expectancy is about 54 years. The infant mortality rate and the under 5 mortality rate and the maternal mortality rate are quite high. And literacy rate is also on the high side for the region at about 62%. And you'll remember the graph here showing the distribution of the causes of death here. And here we're showing the distribution of the numbers of death. And in large part, most of the deaths occurring in Nigeria are in the infectious disease realm, followed by the non-communicable diseases and injuries. So dracunculiasis or Guinea worm disease is unlike the viral infections we've been talking about so far. Dracunculiasis or Guinea worm is an example of a parasitic infection. And it's caused by the ingestion of a parasite called Dracunculiasis medinensis. And it's a seasonal infection, and it has a long incubation period, about 12 months from between infection and the time when symptoms develop. And the symptoms include are those that result from the emergence of an adult worm through skin ulcers. It is not a very deadly disease, but it can be highly debilitating and disfiguring. It primarily occurs in adults, but there are also cases in children. The only treatment is first aid. There's no immunity that is developed after infection. And this was a very common infection in 1986. There were about 3.5 million cases occurring worldwide in about 21 countries. But through disease control and eradication efforts by 2020, there were less than 100 cases occurring around the world, and these were primarily in sub-Saharan Africa and in some of the more challenging places to work, for example, because of armed conflicts and things going on. This is a picture showing a parasitologist that's examining a guinea worm under a microscope. The guinea worms themselves can get to be up to sometimes a foot or even 3 feet long, so you can see them with the naked eye. What's the life cycle look like? Well, basically it starts when the life cycle depends entirely on humans. There is some evidence emerging that suggests that guinea worm could also infect dogs, which really does threaten the potential for an effective eradication program. As I mentioned earlier, for eradication programs to work, humans can really be the only reservoir. So the extent to which dogs may contribute to or serve as a reservoir for guinea worm needs to be further elucidated and may threaten the success of the eradication program more broadly. But the life cycle, for the most part, depends on humans, and it starts with a human drinking contaminated water that contain these sort of these larvae, that live in the guts of these small copepods that you can actually see with the naked eye. But what happens is the copepods and the larvae are ingested by humans drinking the water, and when the copepods die in the process of digestion, the larvae are released into the human gut, and they mate there. And what happens ultimately is that a fertilized female worm may migrate to the surface of the skin over time, and that causes blisters, often in the lower extremities, but sometimes in the upper extremities. And the blisters cause a burning or itching sensation. And what happens is people want to relieve the burning and itching by putting their foot or their arm in water. And when that happens, the worm emerges from the surface and opens its mouth and releases the eggs back into the water, completing the cycle, so that someone else who drinks the water can become infected at a later time. And so that is basically the life cycle, and the process of eradication of Guinea worm is all focused on disrupting the life cycle so that the parasite cannot perpetuate. So this is a picture of one of the skin ulcers. It sort of looks like a bubble in a case of Guinea worm. And when this bubble bursts, you can begin to see, the example of a worm sort of emerging from the ulcer. This is an example of a Guinea worm in the foot, but as I mentioned, you can also see them emerging from the upper extremities as well. And you need to take great care in removing these worms. It can take several days to do it. You need to do it slowly. If you don't, and if the worm breaks in the process, you can cause a really strong inflammatory response in the area of the ulcer, and that can be very debilitating. And when you've gotten the full worm out of the wound when you have this sort of little hook on the end of it there. In fact, what they use to remove the worm from individuals that are affected by Guinea worm is sort of a small stick. Then they slowly roll a little bit of it out each day around the stick. So over the course of several days or a week or two, they slowly pull the worm out of the body. And it's said that the medical symbol of the caduceus represents the stick and the Guinea worm, the process of removing the Guinea worm from the body. For the most part, until recently, it was believed that humans are the only reservoir for Guinea worm, and that means that transmission of Guinea worm can be interrupted by changing human behavior, completely disrupted by changing human behavior. There are some effective interventions to do this with many secondary benefits. And the efforts at Guinea worm eradication have been led by the Carter Center, which is a center set up by former President Jimmy Carter, as well as UNICEF and the WHO. So what are some of the strategies? Well, there's health education, educating people on how Guinea worm is transmitted, how to avoid it. Disease surveillance, so looking for cases and then targeting health education and other strategies like first aid. Treating cases of Guinea worm can result in preventing or disrupting the life cycle. At providing safe sources of drinking water, which also has many other secondary benefits. And in situations where safe drinking water can't be provided, simple filters that you can use that you can pour the water through are effective at filtering out those copepods I mentioned earlier, and can be safe from a Guinea worm standpoint. It may not prevent other pathogens from being ingested, but filtering the water with filters that can be handed out is an effective way to prevent guinea worm transmission. And lastly, treating drinking water ponds with pesticides is another strategy that is used to prevent guinea worm. So in 1999, you can get a sense here of the geographic distribution of guinea worm disease. It was mostly concentrated in sub-Saharan Africa and some parts of Asia. And looking in Nigeria specifically, going back to the late 1980s, there were over 600,000 cases occurring nationwide. And through lots of efforts to reduce transmission, the caseload really dropped. And I had the opportunity to go there in the year 2000 when there were about 7,000 or 8,000 cases occurring nationally. And I ended up going into a part in southeast Nigeria in Ebonyi State in a local government area, or LGA, called Ohaukwu. And that was a place where it was a local government area that had the most guinea worm cases in the country. And that was because for a very long time, in addition to not having access to fresh drinking water sources that were free of guinea worm, there were ongoing tribal clashes that really prevented safe access to that area in the years preceding, and so workers could not get in to begin the process of working in the guinea worm eradication program there. But in March of 2000, a few months before I went, those clashes ended, and it created the opportunity to begin some of the guinea worm eradication work in Nigeria's most endemic local government area for guinea worm. So here's an example of the kind of pond that people might use as a source of drinking water in Ebonyi State in this particular local government area. And here you can see an example of a structural intervention. Literally, it's a tree branch that has been used to prevent people from actually walking into the pond or wading into the pond to fill their buckets full of drinking water, because if people who had guinea worm were to step into the pond, it's possible that they could introduce the parasite into the pond and perpetuate the process. Here's an example of some of the health education materials that you would see. Here's an example reminding people not to go into the water if they happen to have guinea worm, active guinea worm ulcers, where the worms could release larvae and eggs into the water. Another sign here that I was really impressed with, it says there's a notice, and nobody's permitted to use the pond for molding block or selling in the market. Taking a bath around it is no longer permitted, and you should not put your leg inside the pond. And failure to obey the above order, you will pay a fine of 1,000 naira, which is a steep fine, plus one carton of beer, 1 bottle of snuff, and a pound of kola nut. So it's a very severe consequences for going into the pond or using the pond in an unauthorized way. Here's a picture. Here's an example of someone that's filtering the water using sort of a manual filtration process. You just pour the water through the filter, and the water on the other side, and the jug here will be free of guinea worm. One of the most central strategies most central to the success of the guinea worm eradication program in Nigeria was someone called the village-based health worker, VBHW. And they were responsible for both doing the surveillance work, finding and counting all the cases that occur, but also then immediately targeting first aid and health education to begin the process of disease prevention. And so how it sort of worked is there were two components to the process. When a guinea worm case occurred, because the village-based health worker will have gone all around the village to do education around guinea worm. When cases occurred, they would be notified, and then that person goes to verify the case. And in the process of verifying the case, if it turns out to be a case, they will treat it, and that will involve health education to the patient to make sure that they don't go near the water. It involves giving health education to the entire household and to the areas around where the case occurs. They go through the process of checking in the home to make sure that they have filters available so that they can filter the water going forward. If they don't have them, they would provide them with filters. And as part of the surveillance process, they record information about the case. And that information is submitted monthly. And there's also sort of a checks and balances process where there's a field supervisor who works with multiple village-based health workers that through weekly visits verifies the cases that occur. There's also a proactive process that even when cases aren't occurring, the village-based health worker is going through the village, distributing filters, doing health education, and as part of that process, they're often asking, is there anyone here with guinea worm today? And if so, please see me. And then they find prevalent cases that way, and they can sort of go through the same process. So, you can sort of think about, I was working in this particular local government area, and there are many of them in the state. And so there are many villages across LGA, and the information sort of flowed up the pipeline from the local government area all the way to the state level, and then you can imagine all the other states that were doing surveillance and eradication activities, ultimately to Global 2000 Nigeria, which was the organization that was responsible, the Carter Center organization that was responsible for running the disease eradication activities for guinea worm in Nigeria. And you can see the success that has happened since then with 8,000 cases or so in the year 2000, and quickly beginning through ongoing efforts to get to a point where there were 0 cases as early as 2009. Here's a snapshot of what has been happening globally. Again, we talked about 3.5 million people, 3.5 million cases in 1986. And in 2018, there were about 28 cases occurring worldwide. And these are the countries in which that they were occurring. So major progress in eradicating guinea worm disease around the world. In order to be able to provide these numbers, you need to be doing surveillance activities, even when there are no cases occurring, so that you can make sure that there are no longer any transmission happening. But I was very excited to see this report in the New York Times a few years ago, 10 years ago now, that showed the last known person to have guinea worm in Nigeria, and it was quite a lot of work to get to this place, but it's a very big deal to have come that far in the country. So I'll just stop there and end this week's lecture. We're beginning to move into get through some of the basic principles of the infectious disease epidemiology over these last few lectures. We'll have a few more before we get into some of the more content-specific areas and disease-specific lectures as we move forward. But I hope you all have a great week. Take care.